Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN, Healthy World, Healthy Nation, Healthy You. I'm Nancy Valentine, PhD and registered nurse, and this show is dedicated to you, the healthcare consumer. And today we're having another show on cardiology as part of our cardiology series. And this one is going to be about oral anticoagulants in atrial fibrillation. We already had one show on some basics of atrial fibrillation, which we will repeat today so that you will really understand what we're talking about. But the title for this show is New Therapeutic Options for Stroke Prevention, which is a major complication of atrial fibrillation. And we want you to know how to weigh in which drug may be best for you and your situation. So to talk about this today, let me just give you another prompt on atrial fibrillation. And so let me just share this with you. Atrial fibrillation, also known as AF or AFib, is an irregular and often very fast heartbeat. You may have that problem, or you may certainly know someone that has that problem. This may cause symptoms like heart palpitations, your heart really beating like almost out of your chest, fatigue, and shortness of breath. Treating atrial fibrillation is really important, and it's really critical because it can cause a stroke and negatively impact, obviously, your quality of life. While the condition isn't considered life-threatening, people with AFib are 5 to 7 times more likely to form blood clots and suffer a stroke, which is really the thrust of what we're going to be talking with you about today. Because you may have atrial fibrillation and be able to live with it for many years successfully if you're treated well, and that's what we're going to be talking about as well. So fortunately, atrial fibrillation may be treated with medication. There are some other options, but we're really going to focus today on the medication management of this disorder. And really to educate us about this is a very expert person that we have right here in our city of Philadelphia at the Jefferson School of Population Health, Dr. Joseph Jackson, who is a PhD in pharmacology from the University of Mississippi. And he has a really great background in this. In fact, I went to hear his presentation on all these various medication options not that long ago at the Jefferson School of Population Health, and I felt that it was very important that we really share all this information with you, the healthcare consumer. So today we are really going to focus on what are these options? You know, what is it? What does it look like? What are the options? We're also going to talk about some of the drugs that you may have already heard about, you may be on, Coumadin, and why that is so effective. But he's also going to share with us the new kids on the block, some of the new medications which have been found to be potentially even better. So Joe, thank you so much for being with us again. And I'm really looking forward to this because I've heard something about these new drugs, but let's just start at the beginning with atrial fibrillation. Did I do a good job of explaining that, or what would you like to add to that?
Sure. You did a great job.
Thanks.
I do think that these drugs, when your atrial fibrillation becomes what doctors call permanent or persistent, in other words, it's not going to go away, and it's kind of a hard condition to fix. Mm-hmm. So sometimes when you have a heart attack, they put a stent in, and for all practical purposes, your heart is working better.
Right.
Atrial fibrillation is much more subtle, and some of these drugs are often called blood thinners.
That's right.
Because it changes what we call the coagulability of the blood, and therefore you don't form as many clots.
Is that why you want it thinned? I mean, again, we want people to understand that term.
When you have atrial fibrillation and when the heart doesn't beat regularly, the blood doesn't flow through the heart the way it normally does. And when it starts to pool in places that it shouldn't pool,
like inside your heart,
then you get clots, and those clots often travel up your aorta to the brain.
Right, because it is all connected. The heart with the various veins and arteries, and your head, they're not that far away from one another. And again, I think we have to simplify for people to understand just if you have that condition, how fragile it can be. There's not that much space.
And if you have the condition called permanent atrial fibrillation, your stroke risk is about 5% a year. That's a lot. And when you take these drugs, these oral anticoagulants, you can drop that stroke risk down to 1.5% a year.
That's dramatic.
That's dramatic. That's a 67% improvement in the rate of strokes. So it makes warfarin one of the most effective drugs in cardiology.
Right, which is another name for Coumadin.
Right, which is another name for Coumadin. And it was through that effectiveness that people realized that they should be using more warfarin. However, warfarin is a bit of a tricky drug to use, Coumadin, because you need to maintain a good, what's called therapeutic range.
In the blood.
In the blood.
And how do we know that?
They do test. They do a blood test called an INR, an International Normalized Ratio.
Okay.
And if it goes over 3, then you're set up to have bleeding. And if it goes under 2, then you're set up to have strokes. So they want to maintain that sweet spot of 2 to 3.
Now, wouldn't that be pretty much predictable if a person was taking the diagnostic amount, the therapeutic amount that was not diagnostic, but what was actually given to them by prescription, if they were taking that therapeutic level, which really underscores why it's critically important that when you have these medications, you take them on a regular basis.
Absolutely. Any drug that you take for an effect doesn't work if you don't take it.
Right, but this one even more critical because of that very narrow blood range. So
that's right.
So when people go for that test, which is fairly frequently, isn't it? That
once a month, usually.
Once a month.
After they've been stabilized.
Okay, so some of the early testing is to get it stabilized, to sort of figure out what is the right dose for this person. Exactly. Okay, how long does that take?
Usually a month, 6 weeks, 8 weeks sometimes.
Okay.
Some patients do their warfarin management really well, and they're almost always in that sweet spot of 2 to 3.
And what do they do that's so different?
They're probably just good warfarin candidates. But warfarin has a lot of things that interfere, like if you eat leafy green vegetables and broccoli and spinach, you can throw your warfarin levels off.
I see.
And there's a lot of sort of nuances to taking warfarin that will make you go up or down. If you don't take your medicine regularly, it'll throw your levels off.
Right, right.
There are many, many things with the use of warfarin, especially in seniors. And most of the people who get atrial fibrillation are seniors. I should say that right up front. The distribution for people who are atrial fibrillation usually starts about 60 and peaks about 70 and starts to fall off as you go on in time. So think about the way seniors eat, think about the way seniors, how active seniors are and whatnot, and there's a lot of these things that can interfere with you staying in the sweet spot.
Right, so it seems like when you have a diagnosis of atrial fibrillation and you are given medication, not only do you have to be compliant, meaning that you take it at the same dose, same time of the day, you take it as frequently as it is prescribed, but it sounds like there are other lifestyle issues that you need to be educated on.
Absolutely. Let me just give you one more. I remember seniors, and who takes most of the drugs in the country? Seniors. And warfarin is probably the #1 drug for drug-drug interactions. That can throw off these numbers.
So explain that to our audience.
Well, if you're taking a drug like fluconazole for it's a fungal antifungal drug, it can throw the numbers off. So if you're taking a drug like cardizem for your heart, a calcium channel blocker, it can throw the numbers off. So these are the drug-drug interactions. In fact, among all the drugs out there, warfarin probably has the longest list of drugs that interact with it that can potentially throw the numbers off.
Interesting. So I think the takeaway there is you do need to have your own list of all the medications that you're taking, and a little 3x5 card, anything that you can find handy to have in your wallet or your purse, because you need to review that drug list with any physician that you go to. One of the things that people don't recognize is that maybe you're a primary care doctor and maybe you're cardiology doctor or some other physician that you may be seeing or other treatment group that you're interacting with, they have to do what is called medication reconciliation, but it doesn't always happen. That means they have to do the checks and balances to be sure that all the drugs that you're on, A, you need them all, and secondly, this drug-drug interaction really has to be taken into consideration for what you just mentioned.
And Nancy, let me point out another
Okay.
discipline that is very important, and that's your pharmacist. Your
That's
pharmacist knows a lot about all this, and your pharmacist can be a great advisor to both your physician and yourself.
Right. So based on that is really interesting. So say you were in one of the big box pharmacies and you were picking up your medication. Is it a good idea to just sort of show the pharmacist all the medications you're on?
Definitely. And in the case of warfarin, you probably should, because pharmacists will know which drugs are more likely to interact than other disciplines.
That's really great.
I mean, sometimes pharmacists know it better.
Well, that's true, because that is their field.
Yeah.
But I think, what I like about that piece of advice and that tip is that it's easily accessible. I mean, that's something you can do when you're just picking up your medication.
But you have to ask. The pharmacist will not come out and talk to you unless you ask, for the most part.
That's right.
So it's important to be your own best friend in this medication exercise.
Right. Well, that's part of the reason we're having these shows and these conversations for you, so that you really are empowered with information, knowledge, and just the prompts to do exactly what we're saying right now. Ask and be your own self-advocate. So this would be a good example of doing that.
Yeah. So let's talk about the new kids on the block.
Yeah, that sounds good.
So for many, many years, 50 years, warfarin's been out. And warfarin, as I said, was one of the most effective cardiology medicines out there.
It obviously saved many lives.
Saved many lives. They say if everybody was in range, everybody that could take warfarin was in range, we would avoid 40,000 strokes a year.
Wow, just think of what that means in terms of quality of life. I mean, 40,000 people, is that just in the U.S.?
That's just in the U.S.
Wow.
And that was before this big baby boomer
Right.
Body of people started to turn 60. Because once you start to once you reach your 60s, your chances of having atrial fibrillation are going to go up a bit.
Right. Well, we didn't really talk about what some of the causes are of atrial fibrillation, so maybe we should just review that next.
I'm not sure I know all the causes. I'm not a medical doctor.
Right.
I'm only a PhD.
Okay, but you're in the field.
But the fact of the matter is sometimes the heart wears down, and if you can't fix it with either a stent or a cabbage or something, then you're going to have to live with your atrial fibrillation. And there are drugs that you can take to kind of get your rate improved or your rhythm improved, but they don't work quite as well as they need to. They're not a complete fix. No drug is perfect. And so it's what you find is that a lot of these people get set up for permanent or persistent atrial fibrillation.
Right. So part of it is an aging factor for some people.
That's right. Your hearts are wearing out.
Right. Sometimes it's also as a result of surgical intervention. I know in the case of my father, after he had a very successful quadruple bypass, one of the takeaways within a month or two is he had atrial fibrillation for the next 10 years.
That's right. And not everything is a perfect fix.
Right.
Probably saved his life.
It did.
He has collateral blood flow now to his heart that he didn't have before he had the bypass, but it still is a heart that has given you a big sign. It's like one of those cars that's starting to get older, and you're having to take it into the garage a bit more often.
Right.
Right. In order to keep it going.
Right. So I think that, again, sometimes you don't know what really causes this. It may not be as dramatic as a surgical intervention. It could be just an age thing. There could be family genetics that are playing a role in this. But nonetheless, what is really interesting and what Joe shared with me is the chart of the number of people. It's just one of these charts that goes way up, very steep. You wish it was like a stock chart, like something that you had invested in. But in this case, it's the number of cases of atrial fibrillation, and it's just going up because, as he said, with the baby boomer population and people getting older, there's just so much more of this that we were going to get back to the new kids on the block of new drug options, because researchers were seeing this and they knew that there may be some other ways to handle it. Even though they had a very good drug, as we've already said, there is some downside to Coumadin, because if you're not within that very narrow range within your blood levels that gets tested once a month, you can have other things that happen. For instance, again, I'm just using an example. My mom fell down and she was on Coumadin and she had a very large bruise as a result of that, because your blood is thinner. You know, you do have some other things that you have to be very mindful of and could become a problem. So tell us what really did incentivize these researchers to look for some of these new blockbuster drugs.
Well, Coumadin is a lot of work. You know, when you go on Coumadin, you sometimes have to rearrange the furniture in your house because you don't want to be bumping into
Right.
furniture. You're going to become a Christmas tree, as my mother once said. She was in an assisted care facility, and I mentioned a bruise one time, and she said, "Oh my goodness, it's like Christmas around here. Everybody lights up with bruises."
At least she had a sense of humor.
Yeah, but these new drugs came about after years and years of trying, and nobody ever expected them to be more effective than warfarin, because very effective drugs, 69% relative risk reduction,
Right.
you know, reduction in the level of strokes. But they turned out that they were. And so dabigatran, also known as Pradaxa, rivaroxaban, also known as Xarelto, and apixaban, also known as Eliquis. You've probably seen these advertisements on television now about atrial fibrillation and living with atrial fibrillation. Well, these new drugs were thought that they would only tie warfarin when they were studied, but they did better.
Really? So that was a real aha.
That was an aha. All three of them were published in the New England Journal of Medicine, one of the best journals in medicine today, and all three of them were accompanied by editorials which said, "This is a new era."
Right.
A new era for treatment.
So that is really a remarkable breakthrough in a field that in that area really did have, you know, sort of a steady state, an equal state.
And the thing about these drugs is that you don't need to do the testing, the INR testing, to see if they're in range.
How do you know if they are?
Well, they're inherently, the mechanism of action, you know that they are because they did the studies to show that the strokes were not there, and they were more effective with in some cases a little less bleeding.
Right. So that's a really great outcome.
Especially the kind of bleeding that's into the brain. We call it hemorrhagic strokes or intracranial hemorrhages.
Now that is a different stroke than what we were just talking about earlier, which was the one that is caused by clots, pooling in parts of your body, but most frequently perhaps in your heart. This is a different kind of stroke. Can you explain the difference?
Well, remember I said these are blood thinners. And so sometimes you have clots in your brain that are called hemostatic plugs, or in other words, clots that shouldn't be dissolved. Well, some of these drugs, warfarin, all of the anticoagulants, have the potential to dissolve clots in the brain that causes the brain to bleed.
I see.
And that's not good.
Right. That would sound like very not good.
That's a very dangerous.
Right. How do those clots get to the brain anyway? Are they just part of, again, normal living?
Normal living.
Right.
Normal living.
So you might be like hit your head and you have a little clot and it just sort of sits there for the rest of your life.
Well, the brain, the body will heal itself.
Right.
For the most part. And so when you're talking ICH, you're talking something that's either an outside injury, that you've fallen down and you have a bleed into the brain, or it's part of a normal process.
Right.
The brain is taking care of itself.
So this really had two wonderful outcomes. One is that you don't have to go through all that testing and really be on top of that particular detail. And there is less bleeding, so that would mean, you know, less bruising, potentially something as dramatic as less hemorrhagic strokes.
That was the real surprise. Nobody expected the hemorrhagic stroke finding. That was the real aha moment for the medical community. But they come with a price. Remember I said warfarin is very, very effective. And when people use warfarin the way they're supposed to, at INR of 2 to 3, then it's hard for even these new drugs to beat that, right? And the new drugs come at a much higher price.
You mean out-of-pocket price?
Out-of-pocket price.
Okay.
And sometimes, remember I mentioned the formularies in the last session we had. Well, formularies will be concerned about the total cost of the drugs because all of these institutions have budgets.
Right.
And so if they have to spend a lot of money on new anticoagulants, then they're not spending it on something else that they could be buying.
Right. So a formulary, which I'm going to ask Joe to explain to us again, is really like a dictionary of drugs that a particular organization will sanction that the doctors can use and prescribe. Not every drug is on this list. And sometimes there is fussing among the medical community. They'd like to see certain drugs on the formulary, and the people that control it, which are often the administrative people that are really running the healthcare organization from a cost perspective, are saying, we can't put every drug on, because if we put every drug that you or your group would like to see on there, we wouldn't have enough money to pay for all this. So we have to really, slice it down to what we think are the most important, the best value drugs. But I guess this is really pushing the envelope on some of that. Some
people call these positive lists and negative lists.
Oh, really?
And a positive list would be a drug that almost everybody should be using. Mm-hmm. It's really a good drug. In fact, the World Health Organization calls them an essential medicines list.
Okay.
That every drug, like penicillin, it would be an essential medicine.
Right. You wouldn't have any debate about that one.
No. And aspirin probably be an essential medicine. And some of them call these other drugs negative lists. Well, that's a drug that you should really steer clear from or not use very often.
Negative in what regard? What's the criteria for negative?
Well, negative could be anything. It could be a question of safety. Could be a question of not very much efficacy. Mm-hmm. A few years ago, the FDA came out with a list of what were called negative list, or were called DESI drugs, and I can't remember what DESI stands for, but the vasodilators fell into those DESI drugs, meaning that they weren't effective. So they were on the market, but they really weren't effective.
Right, but the drugs that we're talking about in this case with the atrial fibrillation, they wouldn't be on a negative list.
No, they would definitely be on a positive list. But I'm saying the formulary would evaluate what are their preferred drugs.
Right.
And they would put together a little dossier, a little story, a little consumer reports for their doctors to say, we've evaluated the evidence behind these drugs and we can stand by them, and we hope that you would feel the same way, and we'd be happy to sit down and talk to you about it. And for the most part, that's the job of the pharmacist, to sit down and talk to the doctors about their drugs.
Right.
The pharmacists who work on these big institutions,
right.
Clinical pharmacists.
But from a cost perspective, when you think about how much all the testing costs, tests cost money, getting to the tests, just the time that it takes for people, but I mean, just even the expense to the healthcare system, if you took that whole piece out of the equation, would that offset the cost of these new drugs?
Somewhat. And it's a very astute point on your part, because you need to have the test to stay in that range, right? And getting to the testing is not always easy, especially for a senior. Maybe they shouldn't be driving. Maybe they have to have somebody come and take them.
Right.
And then you get to the test and maybe they're not ready for you right at the right time, and so you spend a couple hours doing things that you'd rather not be doing.
Right.
And so there's that aspect of it, and then there's the difference in efficacy. The real cost comes in the difference in the stroke rate.
Right. So if it really brings down the strokes even more than Coumadin, and it really doesn't have the brain bleeds that you talked about earlier, that's
right.
A huge cost.
So
savings.
My discipline would look at all the evidence, and it would look at the excess strokes, the excess testing, and it would roll all that up into what we call cost effectiveness.
Okay.
And on the one arm, you'd have all of the effectiveness of warfarin versus all of the effectiveness of the new drugs. Then you'd have all the costs of warfarin, and then you'd have all the costs of the new drugs. And for the most part, the drug costs are high enough that you wouldn't be equal. The drug costs would still make the total column, even with all the fewer strokes and the more testing, would still make these drugs higher than warfarin. But we would call that cost effective. In other words, a good value.
Right, right. So you're paying slightly more, but you're getting something for it.
That's right.
Right.
It's kind of like the difference between buying a regular Chevy or Ford and buying a Impala or a Cadillac or a Mercedes.
Right.
You know, you're paying a little more, but you're getting a little more.
Right, right. But this is not just another pretty drug. I mean, this sounds like you really get something that is really substantial out of it, that's really worth having a conversation. Now, let's get to that in our closing, because lots of our listeners will be on Coumadin, and they will have maybe had this conversation with their physician, or maybe they didn't because they weren't even aware of these new kid on the block drugs. How would you suggest our listeners approach their treatment team about this?
Well, I think that your treatment team is very aware of some of these issues. And so if you're the kind of person that has a difficult time staying to a diet that doesn't interfere, or having a lot of drugs that might interfere, or not staying in, you're the kind of person that doesn't stay in range, you'd be a better candidate for the new drugs than a person who stayed in range.
Well, that's a very good point. So if you really have had excellent compliance and you really see no reason to make a change, and your physician can substantiate that with you, then this would be maybe less of an issue.
Exactly right. Remember, I said warfarin is a very effective drug. These drugs are more effective, but it almost is a personal choice. And frankly, you should understand your finances too.
Say more about that.
Are you willing to pay a little bit more to maybe have a little bit easier time of it in your management of atrial fibrillation? Mm-hmm. You know, it's almost like, are you willing to pay a little bit more to have an addition put on your house? Or, you know, you think about all the things that you think are valuable.
Right.
And this is one of those things. So how much is your time worth, and how much do you want to put in the extra investment in order to get some good value out, but it's still going to be a little bit more?
Well, I think that's really great advice and some very, very important tips that you can take away. On our website, when this show is posted, those drug alternatives will be listed out. So if you didn't catch the names, as Joseph was telling us, they will be listed just so you have that as a reference. But I think that his background and field in outcomes research and really looking at the difference between different alternatives, in this case, drugs for atrial fibrillation, has really helped us and helped the whole healthcare community make better choices. And that's really a big part of this show, is to help you be informed so that you can make better choices along with your treatment team. So I want to thank you very much for being with us. I want to thank Dr. Jackson for being with us again and imparting his exquisite knowledge with us. It's just been a pleasure to have him, and I'm sure we'll have him back again because he is a wealth of information. So I want to thank you for being with us, and again, I want to hopefully invite you to come to our website so you can see this and other shows at www.drnancyrn.com. And remember, with health, all things are possible. Thank you very much. Have a wonderful day. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening, and join us again. And remember, with health, all things are possible.